Hello, everyone. This is a new topic here in DBT Intensive, and it's the suicide crisis protocol. Very important topic, obviously, and at the core of DBT, when you consider that Marsha Linehan was first and foremost a suicidologist, a suicide behavior researcher, and that is really what led her to develop DBT, was to reduce suicide attempts, self-harm behaviors, and other related behaviors. So this is at the core. It's really important. So on the other hand, isn't all of DBT a suicide protocol? You might say suicide treatment protocol. And I would say, yes, it is. So what's different about this one thing that we're going to talk about now is that it's the suicide crisis protocol. If you remember suicide types of behavioral targets, if you were listing a person's primary targets for treatment, very high on that list are life-threatening behaviors. Very high among those behaviors are suicide behaviors. The highest suicide risk behavior out of a list of 5 types is the suicide crisis behaviors. And those are the kind of behaviors that make you worry as a therapist that, you know, the person might be dead before they see you again, based on their suicidal risk factors. So this is when there's an acute episode of elevated suicide risk compared to your usual suicide ideations for a given client. And you have to use people as their own baseline for this. So for instance, on a diary card, if somebody presents with a suicide ideation or suicidal urge of 4 out of 5, and they're usually at 2, that's a crisis. If they present at 3 and they're usually at 1, that's a crisis. And generally, Linehan has recommended that if somebody jumps up by 2 points over their usual baseline, consider that a crisis. It's also a crisis just if you're in the middle of a session and you learn about the current situation and the current clinical status of the client, and it's obvious to you that, you know, there's a higher suicide risk, and you feel you need to depart from business as usual in order to focus in on that. And that's what this protocol is for. It's really to depart from usual business, which is to try to work towards a life worth living and lowered suicide risk as a result of that. And it's to zero in because things are getting close to where you think it's more dangerous. And it isn't like there's anything brand new in the protocol. It's a combination of a lot of elements of DBT, and I want to go over it with you. And the main ingredients in the protocol are, first of all, suicide risk assessment. What are the factors you consider to tell you if you think that there's elevated risk, and to confirm that there might be elevated risk. As difficult as it is to predict suicide, there are still a number of statistically based risk factors that at least correlate with completed suicides. And then there'll be the protocol will move into what do you do. So it's the risk management part. I'm going to talk about the suicide risk factors and assessment, and then also at least orient you briefly to the Linehan Risk Assessment and Management Protocol, or the LRAMP, Linehan Risk Assessment and Management Protocol, which is now has been developed and is a 7-page step-by-step way to assess suicide risk, document it, make decisions about what to do about it, document that, and then have a disposition at the end of that, document that. And so it helps you think clearly, helps you stay on track, and also helps you have documentation for how you've thought it through, which could be useful for all kinds of reasons. All right. So I'm going to go through slides and then depart from slides now and then to just talk a little more. But the first slide is a title slide among the slides. It's the DBT Suicide Risk Protocol. It says Guidelines for Suicidal Crises, Suicide Risk Assessment, LRAMP, and the suicide risk protocol. Okay, so let's start with guidelines. These are like general guidelines for dealing with suicidal crises. They aren't the protocol. They're kind of the background of the protocol. And I have 3 slides about this, which adds up to about 12 different guidelines. So let me go ahead with that. First, you have emotions there to contact, to touch in the patient, and you also have content. The patient may be telling you about the situation, and you may be tuning into the content, tuning into the affect. And the first guideline is just to realize the extreme importance of connecting with the affect, tuning to affect, validating affect. If you had to make a choice, which you might not have to, you want to prioritize making an affective connection, attunement, over getting all of the content and going over content. You can go over content, and if you don't make a connection, it probably won't reduce the risk very much. But sometimes just making a really good connection, hearing the patient out about their suicidal thinking, their suicidal planning, their suicidal affects, can be helpful. Okay? Second, explore the problem now as opposed to long term. In other words, somebody might want to start telling you why they need to die. That goes back years of hopeless, of episodes in their life, of factors in their life that generate hopelessness, all of which might be worthy of discussion, but not during the suicide crisis, because actually to go into those probably just heightens the sense of hopelessness, and it's hard to counter things that go way back. So what you really want to focus on is what's been going on since the last session and in the last couple days, that has really brought suicidal risk or crisis or ideation or urges to a higher level. Okay, so it's a focus on now rather than reviewing history. The next guideline is if you have a choice between focusing on emotional tolerance, tolerance of distress, affective tolerance, as opposed to changing affect, transforming your emotions, you want to probably highlight affect tolerance techniques, affect tolerance concepts, because you might not be able to change the emotion right now, but you might be able to help the person ride through the current level of distress until things can go down. So prioritize affect tolerance. Next guideline is to, while you're interacting, you want to prompt and reinforce the patient for taking action towards safety themselves. So anything at all, even if they're highly suicidal, if you can pull for behavior that's to attempt to remove themselves from the means, let's say, for suicide, or the location that they're more likely, or to take action to get away from a person whose presence triggers the increased likelihood of suicide. Anything they can do to take action themselves and not just become the passive recipient of all of your efforts. Next guideline. It isn't like there's any one thing that's the right thing to do here. You really have to explore, use these guidelines, use the protocol, but it's a lot of kind of feeling your way, trying things, prompting things, assessing where you're at 10 minutes down the road of these kind of interventions, and being flexible in what various things you're considering, whether it's hospitalization all the way out to no major intervention. Or having them team up with someone else, or be with somebody, or having them have a check-in with you later in the same day or the next day, or more frequent sessions briefly, or something like that. Whatever you're going to be considering doing, make it flexible, ranging from the most aggressive, I'm gonna have to take over, to staying back and letting the client generate safety-promoting behaviors. Next one, be willing to openly discuss and listen to discussion of suicide. There's nothing really positive to be said for telling the patient that discussion of suicide is off the table. which is what I've heard sometimes people say. No, if anything, that increases the pressure towards suicide. The person is more alone with the thoughts of suicide. So you want to be willing, not that you want to spend a ton of time on it, at least during a crisis, but you want to be willing to hear that they're thinking of killing themselves, and and they might say something about, why that's coming about. And then you want to get some assessment of that and the likelihood of that, and then consider what to do, to try to reduce the risk until your next contact. This is an until your next contact kind of protocol, all right? What else? It can be very helpful as a guideline to make comments that indicate that you understand suicide is, from the patient's point of view, suicide would be a solution to problems. And even though it's a problem in itself, really the more important understanding and the more validating understanding is that, okay, so you've arrived at suicide as a solution. So let's talk about the problem and what has escalated the problem and what we can do about that. Next guideline, be steadfast and explicit in arguing or stating that you don't think suicide is a good option, that it is an irreversible solution to what can be a reversible set of problems, and that you're just not ready to go there. You couldn't support that right now as a plan. You won't help support that. You won't help figure that out. And just keep maintaining that you don't think it's a good option. Your patient, it may be sounding you out or reading between the lines, saying to themselves, does my therapist think that suicide is okay? Does my therapist actually quietly think it's the best thing to do because the therapist just can't say it out loud? So you want to be clear to drown that out, any fantasy of that. Next guideline, schedule contacts frequently enough, and there's no real guideline right here. I wouldn't overdo it, but I really don't want, if it's too much, then the person probably should be at another level of care if that's the only thing that you think is going to work. But I would increase the frequency of contact. A contact could mean checking in by phone, leaving voicemail for you to tell you how things are going, maybe scheduling an extra appointment that week, or checking in briefly in brief appointments through the week. Okay. Another guideline, which is different than standard DBT, is to more involve significant others. So you're getting at a point where suicide is a crisis. It could happen. The risks are up. The door is open, so to speak. And this is the time to consider whether there are certain supportive, significant others in the patient's life that you might involve, that both will help with making clear the point about trying to address this firmly, but also brainstorming solutions with other people who have often more contact than you do with the client. Next one, avoid putting yourself in the position of being the omnipotent rescuer, the one who feels that this is my job, this has come on my shift, and I'm going to handle this. And it can, for some people, really activate the sense of, I am the omnipotent rescuer, I'm going to do this, I don't know what other people think. Going out of your way, I'm going out of usual protocol. Be careful about that. It can be a temporary state of mind, which actually can increase the risk for the patient and increase your own risk as a therapist in a number of ways. What you want to be doing is trying to coordinate this in concert with colleagues or team members or even a consultant. Final general guideline is to focus yourself on problem solving. You're going to hear that throughout the protocol. Though you do start by validating and hear about suicide, you really want to be making suggestions, giving advice, being more directive than usual, suggesting skills, framing solutions in terms of skills, predicting future consequences of behavior, and sometimes confronting the patient's maladaptive ideas. Okay? Be back with you in the next video to move on to the protocol.